Well, it's 2:30 Eastern time, and so I think we can get started with our presentation. So welcome to today's Diabetes and Youth Interest Group webinar on the ADA's 2022 Standards of Medical Care in Diabetes for Children and Adolescents, including transitions to adult care. My name is Dr. Jean Lawrence. I am the chair of the Diabetes and Youth Interest Group and the Senior Advisor for Diabetes Epidemiology at NIDDK. Now I will introduce our speakers, who are both members of the ADA's Professional Practice Committee. We plan to have time for a few questions at the end of the session after both have completed their presentations. You can put your questions in the Q&A or in the chat. Dr. Priya Prahalad is a clinical associate professor in the Department of Pediatrics, Division of Endocrinology, and a medical director of clinical informatics at Stanford University and Stanford Children's Hospital. She is board certified in pediatric endocrinology, pediatrics, and clinical informatics. Her clinical and scholarly work aims to use technology to improve clinical outcomes and quality of life in youth with type 2 diabetes. Dr. Sarah Lyons is an associate professor in the Department of Pediatrics, Division of Diabetes and Endocrinology at Baylor College of Medicine and Texas Children's Hospital in Houston, Texas. She is a med-peds endocrinology with residency training in internal medicine, pediatrics, and dual fellowship training in pediatric and adult endocrinology. She is board certified in internal medicine, endocrinology, diabetes, and metabolism, and pediatric endocrinology. Her clinical and scholarly work aims to improve medical care and health outcomes of children, adolescents, and emerging adults with diabetes, particularly during their transition from pediatric to adult care. So I would like my speakers now to take it away and tell us a bit about the standards of medical practice.
Great. We just wanted to, first of all, I'd like to welcome everyone to this presentation. Thank you for taking the time to hear some of the updates to standards of care. And Sarah and I wanted to just share our disclosures prior to the presentation. And so what we'll be discussing today is the standards of care in diabetes for children and adolescents. This is one of the largest sections in the ADA standards of care. There are over 100 recommendations, so we won't have time to go through every single one of them, but we really want to talk about the changes that we've made to the standards over the last year. So the goal of the standards of care is to provide clinicians, patients, researchers, and payers with components of diabetes care, general treatment goals, and tools to evaluate the quality of care. And we use a very evidence-based process to develop these recommendations. So the Professional Practice Committee is a multidisciplinary committee that's comprised of physicians, diabetes educators, and others who have a range of expertise in areas not limited to adult and pediatric endocrinology, epidemiology, public health, cardiovascular management, microvascular complications, preconception and pregnancy care, weight management, and diabetes prevention, as well as the use of technology in diabetes management. Appointment to the PPC is based on excellence in clinical practice and research. And so the members of the PPC search the scientific diabetes literature over the last year to revise recommendations based on new evidence. Once the recommendations are made, the standards of care are reviewed by other members of the Professional Practice Committee, the ADA's Board of Directors, and the standards of care is a living document, which I'll talk about in the next few slides. And funding for this comes from the ADA's general revenues. There is no industry support. And so, as I mentioned, starting in 2018, the ADA Standards of Medical Care is a living document where updates are incorporated into the standards throughout the year. The updates will be made in response to important events, such as the approval of new treatments, which could be either medications or devices that can impact patient care, the publication of new findings that support a change to the recommendation or an evidence level of a recommendation, or a publication of consensus documents endorsed by the ADA that necessitates an update to the standards to align with the content of these documents. As I mentioned, these recommendations are graded based on guidelines set by the ADA. So recommendations range from a level A, which is the strongest recommendation, to a level E. Level A recommendations are clear evidence, typically from well-conducted, generalizable, randomized controlled trials that are adequately powered. There can sometimes be recommendations based on compelling non-experimental evidence or supportive evidence from well-conducted randomized controlled trials that are adequately powered. Level B evidence is typically supportive evidence from well-conducted cohort studies or well-conducted case control studies. Level C evidence is supportive evidence from poorly controlled or uncontrolled studies, or studies with conflicting evidence with the weight of evidence supporting a recommendation. And then level E evidence is expert consensus or clinical experience. We may see a little bit more level E evidence in the pediatric or child and adolescent guidelines, just because studies have not been always completed in this age group. So I'm going to hand this off to Sarah to discuss the guidelines.
So to start with, section 14 on children and adolescents is divided into essentially two halves. The first half is for type 1 diabetes, and the second half is for type 2 diabetes. For children and adolescents who have other types of diabetes, in the introduction of this section, it references the appropriate other sections of the standards of care to see for those recommendations, such as cystic fibrosis or monogenic forms of diabetes. Next slide, Priya. For this year, we have added 2 summary tables. As Priya mentioned, we have over 100 recommendations in the pediatric standards of care. And so while this is a lot of recommendations, we wanted to make it as easy as possible for clinicians to have just a summary of what that is. And so I'm not going to go through this row by row and line by line, because we'll be talking about that in the upcoming slides. But essentially, the first table is for pediatric type 1 diabetes, and it has the different comorbidities and complications that we are screening and monitoring for. And it has the corresponding recommendation on the first row, the method or how to screen for that, when to start it, the follow-up frequency, what is the goal in the screening, and then if found to be abnormal, what is the recommended treatment. So next slide, Priya. And then this is similar for type 2. And so similar format to type 1, but with the recommended screening for individuals living with type 2. And so more to come on the actual recommendations when we get into the further slides. So next one. So for type 1 diabetes, the first subsection is on diabetes self-management, education, and support. And recommendation 1 has not changed. However, I would like to make a note that in this subsection, in the narrative or the text that accompanies the recommendation, we have further stressed that self-management in pediatrics is never the child alone. It is self-management with an accompanying adult, family, and their support system. And we also stress that premature transfer of responsibilities to the youth should be avoided. And so really thinking about, while this is called self-management, it's really the management of an entire team of people taking care of this, the child living and an adolescent living with diabetes. Next slide. So the next subsection under type 1 is nutrition therapy. And there's no changes in the last year for nutrition therapy. And kind of in summary, medical nutrition therapy should be individualized. The second one is about monitoring carbohydrate is key to optimizing glycemic management. And then the last one of this section is really comprehensive education, both at diagnosis and then with annual updates is important. And the next one, for physical activity and exercise. So and just I should have mentioned at the beginning that there was no changes. We kept the recommendation text in black, and if there was changes in that recommendation, we changed it to red, so it would be easy for you to see what changes have been made in the last year. And so for physical activity and exercise, the new changes on 14.6 with modification of this recommendation with frequent blood glucose monitoring before, during, and after exercise via blood glucose meter or continuous glucose monitoring is important to prevent, detect, and treat hypoglycemia and hyperglycemia associated with exercise. And in the accompanying text, we talk about CGM guidance. General recommendations are for blood sugar or for CGM glucose to be 126 to 180 for the target. However, this should be individualized for the youth. Next slide. Continuing with physical activity and exercise, there's been no other further changes. In summary, this is focusing on youth and their caregivers should receive education on targets and management of their glycemia with physical activity, both before, during, and after. And then should be on the second recommendation on this slide, should be educated on strategies to prevent hypoglycemia and ways to do that. Next one. And then the next subsections on psychosocial issues for individuals with type 1 diabetes. And there has been, for these three recommendations, no change in this. And so as you can see, essentially that it's important to assess psychosocial issues and family stresses that can impact diabetes management. That mental health professionals should be considered an integral member of our multidisciplinary team, and that we want to encourage developmentally appropriate family involvement in diabetes management. Next slide. The next three under this have not changed at all. So the first one is about assessing for social determinants of health. The second one is about asking social adjustment and peer relations. And then the last one is assessing for psychosocial and diabetes related distress. No changes in those. Next slide. And then the last of these for psychosocial, no changes in these recommendations. So offering time for the adolescent to meet with their healthcare professional by themselves, starting at puberty, incorporating preconception counseling, and then beginning screening for eating disorders between 10 and 12 years of age.
Okay, great. So the next section in the standards is talking about diabetes technology as it pertains to children and adolescents. This section has been harmonized with section 7, which is the diabetes technology section of the standards of care. And there were significant changes made to this section, both based on new types of technology available as well as new evidence. And one of the first things we did was actually define the 3 types of continuous glucose monitoring technologies that are available, because there's differing levels of evidence for all 3 types of this. So we call RT-CGM or real-time CGM a CGM system that measures and stores glucose levels continuously without prompting. Then there is IS-CGM with and without alarms. So these are CGM systems that measure glucose levels continuously, but require scanning for storage of glucose values. And last, we have professional CGM, which are devices that are placed on a patient in a provider's office and worn for discrete periods of time. The data can be blinded or visible to the person wearing the device. And this data is used to assess glycemic patterns and trends. And these devices are not fully owned by the patient, so they're clinic-based. And that's why they're different from RT-CGM and IS-CGM. So in the glycemic monitoring, insulin delivery, and target section, we structurally changed the section to have glucose management first and then discuss insulin administration. And again, I want to highlight that when we use the term self-management, it's not just the child or the adolescent with diabetes, but it's the whole support system. So in 14.18, we have not made any significant changes to the recommendations for BGM. So we do recommend at least 6 to 10 blood glucose readings per day by glucometer or continuous glucose monitoring. However, in 14.9, we did make a differentiation in evidence based on the type of CGM. So real-time continuous glucose monitoring is a level B evidence, and intermittently scanned continuous glucose monitoring is an E level evidence. And these devices should be offered for diabetes management in youth who are on multiple daily injections or insulin pump therapy who are capable of using the device safely. So again, either themselves or with their caregivers. And the choice of device should be based on the patient's circumstances, desires, and needs. So we really are trying to show the difference in evidence between these two types of CGM, as well as highlighting the importance of both personalization as well as support. Next, in the insulin delivery system, a big change was made to make automated insulin delivery systems first-line therapy based on current evidence for improving time and range and glycemic control. And so we recommend automated insulin delivery systems should be offered to all for diabetes management to youth with type 1 diabetes who are capable of using the device safely. The choice should be based on patient circumstances, desires, and needs. And recommendation 1421 is that insulin therapy alone should be offered for diabetes management to youth on multiple daily injections with type 1 who are capable of using the device safely. And the change in recommendation 1421 was to change it to a stronger recommendation by using should. And the big difference between 1420 and 1421 is while AID is preferred, we do still recommend pump for people who are unable to access CGM or who do not want to wear CGM, but make an offer of insulin pump therapy. And then recommendation 1422 is the new recommendation. And this recommendation was made in conjunction with the ADA Safe at School Advocacy Group. And so in this recommendation, we say that students should be supported at schools in the use of diabetes technology, including CGM, insulin pumps, connected insulin pens, and automated insulin delivery systems as prescribed by their diabetes care team. And then in talking about glycemia, A1C goals should be individualized and reassessed over time. So we did continue with an A1C target less than 7 for many children. Recommendations 1424 and 1425 are unchanged, but discuss personalizing A1C goals for individuals who are unable to articulate symptoms of hypoglycemia or have other risk factors for severe hypoglycemia. And recommendation 14.26 remains unchanged, where providers can recommend more stringent A1C goals for individuals if they can achieve this without significant hypoglycemia. Recommendation 1427 is new, and this incorporates CGM goal metrics. So continuous glucose monitoring metrics derived from CGM used over the most recent 14 days, which includes time in range, time below range, and time above range are recommended to be used in conjunction with A1C whenever possible. And this is level of evidence E just because we don't have the data yet. And so Sarah.
And so next is autoimmune conditions, and there's been no change in assessing for autoimmune conditions. Next slide. And in particular for thyroid disease, there's been no change in the recommendations for screening for thyroid disease at this time. And then next slide, just keep moving so we can go through all 100.
Yeah.
For celiac disease, there also has been no changes in the recommendation for screening for celiac disease in youth with type 1. So the next one is management of cardiovascular risk factors, hypertension. I will make a note that we'll talk a little bit more in depth probably now in the type 1, but our recommendations for type 2 mirror the type 1 recommendations, and that is because the recommendations come from the American Academy of Pediatrics clinical practice guidelines for kind of shaping these recommendations. This is the 2017 publication screening practice guidelines for screening, clinical practice guidelines for screening and management of high blood pressure in children and adolescents by Flynn et al. And so for this one, for hypertension screening, blood pressure should be measured at every routine visit. In youth with high blood pressure, which is defined as blood pressure greater than or equal to the 90th percentile for age, sex, and height, or in adolescents who are 13 years and older, a blood pressure greater than or equal to 120/80. On 3 separate measurements, ambulatory blood pressure monitoring should be strongly considered, level B evidence. And then treatment of elevated blood pressure, which is defined as a blood pressure of 90th to less than the 95th percentile for age, sex, or height, or in those 13 and older, of a systolic of 120 to 129 and a diastolic less than 180, is lifestyle modification focused on healthy nutrition, physical activity, sleep, and if appropriate, weight management. And then for the next recommendation, in addition to lifestyle modification, ACE inhibitors or angiotensin blockers should be started for treatment of confirmed hypertension, which is blood pressure consistently at the 95th percentile or higher for age, sex, and height, or for those 13 and older, blood pressure of 130 over 80 or higher. And due to, and this is a kind of a change for teratogenic medications, we made stronger language regarding this, but due to the potential teratogenic effects, females should receive reproductive counseling, and ACE inhibitors and angiotensin receptor blockers should be avoided in females of childbearing age who are not using reliable contraception. Next slide. And then the goal of treatment is blood pressure consistently less than the 90th percentile for age, sex, or height, or again, for those that are 13 and older, having a blood pressure less than 130, systolic, and a diastolic less than 80. Lipid, for this particular one, no changes in the screening for lipids.
And so next we'll talk about testing and management of dyslipidemia. So recommendations 1439 and 1440 are unchanged. If LDL cholesterol levels are within the acceptable risk level of less than 100 mg per deciliter, the lipid profile can be repeated every 3 years. And if lipids are abnormal, initial therapy should consist of optimizing glycemia and medical nutrition therapy. 1441 is the same recommendation, but we added stronger wording regarding the potential teratogenic effects. So again, after the age of 10, a statin can be considered, but because of the potential teratogenic effects, females should receive reproductive counseling, and statins should be avoided in females of childbearing age who are not using reliable contraception. And 1442, the goal of lipid therapy is to maintain an LDL cholesterol level under 100. Recommendations 1443 and 1444 are both unchanged, so it's important to elicit a smoking history and discourage smoking in youth. And then electronic cigarette use should also be discouraged. The screening for nephropathy is also unchanged. Annual screening should be started at puberty or age 10, whichever is earlier, once the child has had diabetes for 5 years. Again, we did make a change to our recommendation 1446 on ACE inhibitor angiotensin receptor blocker therapy, again, to strengthen the wording regarding reproductive counseling. So again, due to the teratogenic effects, females should receive reproductive counseling, and ACE inhibitors and ARBs should be avoided in females of childbearing age who are not using reliable contraception. Recommendations 1447, 1448 are both unchanged. 1447 recommends starting retinopathy screening once someone has had type 1 diabetes for 3 to 5 years, once they're over the age of 11 or puberty has started, whichever is earlier. And then after the initial exam, we recommend repeating eye exams every 2 years, and you can stretch this out to every 4 years based on the advice of an eye care professional and risk assessment. And recommendation 1449 is a new recommendation which states that programs that use retinal photography with remote reading or use of a validated assessment tool to improve access to diabetic retinopathy screening can be an appropriate screening strategy for diabetic retinopathy. Such programs should need to have provide pathways for referral for a comprehensive eye exam when indicated. This is harmonized with the recommendations in, I believe, section 11. And this is level of evidence E because we do not have data on this yet in children. And then the recommendations for screening of neuropathy is unchanged, but we recommend an annual comprehensive foot exam at the start of puberty or age greater than 10 years, whichever is earlier when someone has had diabetes for at least 5 years.
So those that summarizes the first half, which is for pediatric type 1 diabetes. And now we'll move to the second half of the section, which focuses on youth onset type 2 diabetes. For screening and diagnosis, for these two recommendations, there has not been any change in the recommendations. 1451 focuses on risk-based screening for prediabetes and type 2 diabetes and when that should be considered in pediatrics. And then 1452 is if screening is normal, then repeat screening at a minimum of every 3 years or more frequently if the BMI is increasing in a child, an adolescent. For these next two recommendations under screening and diagnosis, there has not been any changes as well. So fasting plasma glucose, 2-hour plasma glucose during a 75-gram oral glucose tolerance test and A1C can all be used to assess for prediabetes or diabetes. And children and adolescents with overweight or obesity in whom the diagnosis, if type 2 is being considered, should have a panel of pancreatic autoantibodies to evaluate for autoimmune type 1 diabetes. And then for management lifestyle, there's been no changes for these. So the first one, a youth with type 2 and their family should receive comprehensive diabetes self-management education and support that's specific to type 2. Youth with overweight and obesity and type 2 diabetes should be provided developmentally and culturally appropriate comprehensive lifestyle programs with diabetes management to achieve a 7 to 10% decrease in excess weight. And then the last one is that given the long-term weight management for children, a lifestyle intervention should be based on chronic care model and offered in the context of our diabetes care. And then continuing with lifestyle management, youth with prediabetes and type 2, like all children, should be encouraged to do physical activity with the recommendations of times as you see there. And the nutrition for these youth should focus on healthy eating patterns with the emphasis of nutrient-dense, high-quality food and decreased consumption of calorie-dense, nutrient-poor foods, particularly sugar-added beverages.
In the next section, we'll be talking about glycemic targets in youth with type 2 diabetes. So recommendation 1460 is unchanged, where blood glucose monitoring should be individualized and take into consideration the pharmacologic treatment of the patient. Recommendation 1461 is a new recommendation regarding CGM. So real-time continuous glucose monitoring or intermittently scanned CGM should be offered for diabetes management in youth with type 2 diabetes who are on multiple daily injections or continuous subcutaneous insulin infusion who are capable of using the device safely. The choice of device should be made on patient circumstances, desires, and needs. And so this is also harmonized with the recommendations in section 7 on technology. And recommendation 1462 is unchanged, and that glycemic status should be assessed every 3 months. And then in looking at glycemic targets in people with type 2 diabetes, target A1C for most children and adolescents should be on oral agents should be less than 7% and should be individualized to prevent significant hypoglycemia or other adverse events. And again, this is unchanged from previous years. And then in 1464, less stringent A1C goals may be appropriate if there's an increased risk of hypoglycemia. And then A1C targets for people on insulin should be individualized. All right, next is pharmacologic management of type 2. So recommendations 1466 to 68 are unchanged, but 1466 is initiating pharmacologic therapy as well as behavioral counseling for nutrition and physical activity at diagnosis. In recommendation 1467, we recommend metformin as the initial treatment of choice if renal function is not normal. And in recommendation 1468, in youth with marked hyperglycemia, which is an A1C over 8.5%, without acidosis at diagnosis, who are symptomatic or who have weight loss, they should also be treated with basal insulin initially while metformin is initiated and titrated. And there is a table later on summarizing these recommendations. Recommendations 1469, 1470 are both unchanged. in that individuals with ketosis or ketoacidosis should be treated with subcutaneous or IV insulin to correct the hyperglycemia and metabolic derangements. And then once acidosis is resolved, metformin can be initiated while subcutaneous insulin therapy is continued. And in recommendation 1470, in individuals with severe hyperglycemia, it's important to assess for hyperglycemic hyperosmolar non-ketotic syndrome. Recommendation 1471 was modified to include newer treatments. So if glycemic targets are no longer met with metformin, with or without basal insulin, a GLP-1 agonist should be considered in children who are 10 years of age or older if they have no past medical history or family history of medullary thyroid cancer or MEN type 2. And I believe this recommendation actually was not updated on the slide, so I apologize for that. But the change was, this was the 2021 recommendations, which had liraglutide. But since exenatide is now approved for youth, it has just been changed to be GLP-1s as a class. Okay, recommendation 1472 has been modified as well. So to add pump therapy as an option. So patients who are treated with metformin and the GLP-1 basal insulin who do not meet glycemic targets should be moved to multiple daily injections with basal and premeal bolus insulins or insulin pump therapy. Recommendations 1473 and 1474 are unchanged. 1473 is in patients with insulin metformin who are meeting glucose targets. On home BGM, insulin can be tapered over 2 to 6 weeks by decreasing the insulin dose. And in recommendation 1474, use of medications not approved by the FDA for youth with type 2 diabetes is not recommended outside of research trials. So this is the table that I refer to where we have divided the treatment into 3 different pathways. So A1C less than 5 without acidosis or ketosis, where the initial treatment is to start metformin and potentially adding insulin or a GLP-1. With an A1C over 8.5 without acidosis or ketosis, we recommend metformin and basal insulin. And those who have acidosis, CK or HHNK, we recommend MDI or insulin pump therapy. And again, it's really important to screen for autoantibodies to differentiate type 1, type 2 diabetes. And then recommendations 1475 and 1476 regarding metabolic surgery are unchanged. So metabolic surgery can be considered for treatment of adolescents with type 2 with severe obesity and uncontrolled glycemia or serious comorbidities despite lifestyle and pharmacologic interventions. And 1476 is metabolic surgery should be performed by an experienced surgeon working as part of a well-organized multidisciplinary team.
So I'm going to now discuss the prevention and management of complications, starting with hypertension for type 2. Like I mentioned before, this is overall similar recommendations to type 1, but specified for those with type 2. And so just as similar to type 1, blood pressure should be monitored every visit. And then youth with high blood pressure based on either their age or their age, sex, and height if they're less than 13, or for those 13 older based on the actual number, should be done on 3 separate measurements. And if it's elevated, then ambulatory blood pressure monitoring should be considered. And then treatment of elevated blood pressure starts with, which is 90th to less than 95th percentile for those less than 13, and then 120 to 129 over less than 80. For those 13 older, starts with lifestyle modifications, focusing on healthy nutrition, physical activity, sleep, and then weight management if appropriate. Next slide. And then in addition to this lifestyle modification, ACE inhibitors or an angiotensin receptor blocker should be started for those with confirmed hypertension, which is a blood pressure consistently greater than or equal to the 95th percentile, or for those 13 and older, greater than 130 systolic, greater than or equal to 130 systolic over 80 diastolic. And likewise, as we had stressed in the type 1 half of the section, due to potential teratogenic effects, females of reproductive age should receive counseling, and those who are not using reliable contraception, treatment should be avoided for those. at that time until appropriate counseling and reliable contraception. And then the goal of treatment for blood pressure is to have it less than the 90th percentile, and then for those over 13, less than 130 over 80. Next. And then when we think about, then for nephropathy, there's been no change in this recommendation for protein intake. And then urine albumin to creatinine ratio, there's been no change to the timing and screening. And then there's been no change into the estimated glomerular filtration rate, determining that diagnosis and then annually thereafter. For 1484, there has been a change in such that patients with diabetes and hypertension, either an ACE inhibitor or an angiotensin receptor blocker is recommended for those with moderately elevated urinary albumin to creatinine ratio, which is a ratio of 30 to 299 milligrams per gram of creatinine, and is strongly recommended those with urinary albumin to creatinine ratio, which is greater than 300 milligrams per gram of creatinine, or an estimated glomerular filtration rate less than 60. And likewise, due to the potential teratogenic effects, females should receive reproductive counseling, and treatment should be avoided in those of childbearing age who are not using reliable contraception. And then for 1485 and 1486, there has been no change. So those with nephropathy continued monitoring made aid in assessing adherence and detecting a progression of disease. And then referral to nephrologist is recommended when there's cases of uncertain etiology, if there's worsening ratio or a decrease in the estimated glomerular filtration rate. And then for management of neuropathy, there's been no change, and so still recommended a foot examination at diagnosis and annually using the described method, and then prevention should be focusing on achieving glycemic targets. And then for retinopathy, for these three recommendations, there has been no changes. So screening for retinopathy should be performed by a dilated fundoscopy at or soon after diagnosis, and then annually thereafter. Optimizing glycemia is recommended to decrease or slow the risk, and then less frequent examinations every 2 years may be considered if achieving glycemic targets and having a normal eye exam for those with type 2 diabetes. And then for 1492, this is similar to the recommendation that Priya discussed in type 1 for those programs that use retinal photography. This is the exact same recommendation, which also mirrors the eye section of the standards of care.
Okay, next we'd like to talk about non-alcoholic fatty liver disease. So recommendations 14.93 and 94 are unchanged, but the evaluation of non-alcoholic fatty liver disease should be conducted by measuring AST and ALT at diagnosis and annually. And a referral to gastroenterology should be considered for persistently elevated or worsening transaminases. Recommendation 1495 is also unchanged, but youth with type 2 diabetes should be screened for symptoms of sleep apnea at each visit and refer to a pediatric sleep specialist for evaluation. And obstructive sleep apnea should be treated when documented. And then recommendations 1496 to 98 are around polycystic ovarian syndrome or PCOS. So females with PCOS, females with type 2 diabetes should be evaluated for PCOS when indicated. Oral contraceptives are not contraindicated for girls with type 2 diabetes. And then in recommendation 1498, metformin, in addition to lifestyle, can improve menstrual cyclicity and hyperandrogenism in girls with type 2 diabetes. In looking at the prevention and management of cardiovascular disease, recommendation 1499 involving lifestyle interventions focused on weight loss, improving dyslipidemia, hypertension, dysglycemia are important to prevent macrovascular disease in adulthood. And the recommendations 14100 to 102 are unchanged, regarding lipids. So lipids should be performed initially after optimizing glycemia and annually thereafter. Lipid goals are LDL less than 100, HDL over 35, and triglycerides less than 150. And then if lipids are abnormal, initial therapy should consist of optimizing glycemia and medical nutrition therapy. Much like youth with type 1 diabetes, if the LDL cholesterol does remain elevated at over 130 mg per deciliter after 6 months, therapy with a statin can be initiated with a goal less than 100. And again, we changed this recommendation to include more strong wording around reproductive counseling for females due to the potential teratogenic effects, and statins should be avoided in females who are not using reliable contraception. And then 14104 is unchanged. So if triglycerides are elevated over 400 mg per deciliter or over 1,000 non-fasting, it's really important to start optimized glycemia and begin fibrate therapy with a goal of reducing triglycerides to less than 400 due to the risk of pancreatitis. And then 14105 is also unchanged, where routine screening for heart disease with either an electrocardiogram, echo, or stress testing is not recommended for asymptomatic youth with type 2 diabetes.
And then I will discuss the psychosocial factors for type 2 diabetes. 14106 is a similar recommendation to those with type 1. And so in assessing for social determinants of health, including food security, housing stability, homelessness, health literacy, financial barriers, and community support, and using that information in making treatment decisions. 14107 has not changed either. Using patient-appropriate, standardized, and validated tools to assess for diabetes distress and mental and behavioral health in youth with type 2 diabetes, and then referring when indicated. And then 14108 has not changed either. It is important when choosing glucose lowering and other medications for youth, consider a medication taking behavior and its effect on weight. And then for the last of the type 2, these have not changed as well. So for the first one on the slide, preconception counseling should be incorporated, started at puberty for females of childbearing potential. And then the last one of the type 2 section has not changed either, regarding screening for tobacco, electronic cigarettes, and alcohol use should be done at diagnosis and then regularly thereafter. And then for the very last section, or the very last subsection of the pediatric recommendations, is the transition from pediatric to adult care for youth with diabetes. And these have not changed either. So these recommendations are, pediatric providers on the pediatric side should begin to prepare youth for transition to their adult healthcare starting in early adolescence, and at the latest, it should be at least 1 year prior to that anticipated transfer to adult care. And then both pediatric and adult diabetes providers should provide support and resources for transitioning young adults, and that youth with type 2 diabetes should be transferred to adult-oriented diabetes specialist when deemed appropriate. And so those recommendations have not changed, as the level of evidence has not affected those or the development of new recommendations from the prior year. And so very last, while this is not a recommendation, it is something that we added to the beginning of the section in response to a question that was asked through the ADA portal about recommendations for vaccination. And so just to make note of this, in addition to comprehensive diabetes care, youth with diabetes should receive age and developmentally appropriate pediatric care, including vaccines and immunizations as recommended by the CDC. And so that is all 113 recommendations in about 35-40 minutes. So thank you for bearing with us.
Thank you for the comprehensive presentation. I think if people in the audience can either put a question in the chat or in the Q&A. So one question that came up in the Q&A is, aren't LDL considered elevated if greater than 130?
I believe this was in response to type 1, correct?
Yes, it was. That's when it was posted.
Priya, do you want to do this,
Oh,
or do
yeah.
you like for me to? I can either way.
Yeah, sorry, I thought you were going to answer it, but go ahead.
So I think it was a question in regards to starting recommendations for when starting a statin for individuals with type 1 diabetes. And so let me just make sure I have the recommendation, but essentially it depends on, the current recommendations depend on one's risks for future cardiovascular disease. And so looking at additional risk factors, if there are additional risk factors in youth with type 1 diabetes present, then the recommendation is to start, consider starting statins at an LDL level of 130. And then there are no other risks for individuals without any current risk factors, additional risk factors besides having type 1 diabetes. The recommendation is to start a statin at an LDL of 160. Is that,
Yes, thank you. So the next question is, it says, I feel like the transition portion is so vague. Is there anything in the pipeline to add more clarity to this?
Yes, so this is like an area of interest of mine. I think that as, hopefully more research comes through this, then we'll be able to add to transition. At this point, there has not been any studies that have been when Priya went over the different levels of recommendation, that we have been able to say this is evidence-based to really guide further details about the transition for care. So right now it's kind of best practices based on expert opinion. And these recommendations do come from the transition of care ADA, a larger document that was, I have to look back at the exact date, but by Lori LaFell and Ann Peters, I believe approximately 5 years ago. I'll have to get the exact documentation, but it has much more guidance. But since then, just have not had the the research to really support further recommendations in addition to what we currently have. Hope that helps.
Thank you. A couple people have asked if the slides are available.
Yep.
Are they on the ADA website or?
Yes, so we actually got these slides from a slide deck available on the ADA website. We're happy to share this version with everyone as well, since we've pulled out and highlighted the pediatric recommendations. So Jean, what might be the best way to share this?
I know that there is going to be a recording of this webinar. I'm wondering, we can follow up and find out if there can be a link to the ADA website where those slides reside, and see if we can do it that way. We can check in with our ADA colleagues and find out what the best way is to do that.
That sounds great. Yeah, there's a very large slide deck that has all the recommendations for all the sections, and these slides come from that.
Great, thank you. So the next question up is, which depression, diabetes, distress, and eating disorder screening are institutions using besides the PHQ-9?
Hi, Kristen. I can't speak on behalf of the standards of care recommendations. I can just speak on behalf of my personal institution, which is using PHQ-9. Priya, if you have anything else.
Yeah, I think the standards of care does not specify a specific instrument, and we also use the PHQ-9.
Okay, the next question, is there a reason that meal content, including protein, is not included in the nutritional recommendations as only carbs are mentioned? I think there is evidence.
I want to say, I think that's a great piece of feedback, and we're currently in the process of putting together our recommendations for next year. And so if you do have additional recommendations you'd like us to include, please feel free to share that with us, and we'll definitely take it into consideration and discuss with the committee.
Great, thank you. I don't see, oh wait, is there another, oh, there's another question. Where can I find more information about transition of care?
So the article that I was mentioning before, I can provide you with the link, Jean. Let me find that. I don't have it in front of me, the article, but I can find that recommendation really quickly.
Okay, the next question, more of a research-based question, but as far as the correlation between type 2 diabetes and prediabetes and mental health issues, what studies can you recommend that point to those relationships?
Yeah, that's a great question. I think we'd have to look at them in our reference section. We have quite a few references, but if you look at the recommendation text section, all the references should be in the back of section 14.
And so in that particular question regarding recommendations for the transfer of care, in the references for section 14, it is reference 244, which is the diabetes care for emerging adults, recommendations for transition from pediatric to adult care systems, a position statement of the American Diabetes Association, and then there's other representation of groups. And this is in diabetes care, actually dates from 2011. And so that recommendation is 244.
Thank you. Are there any other questions? All right, any closing comments by our speakers?
I want to just say thank you everyone for attending today. And as I mentioned, we are working on updating the 2023 ADA standards of care. So if you feel like there are any changes you would recommend or any evidence you would really like us to include, please let us know.
And I just want to the ADA does have a formalized process for this as well. And so if you go to the standards of care website, there's a way to submit questions or other kind of recommendations you may have to the standards of care. So you can reach out to us, but there's also a formal way of doing it that then is reviewed through the ADA as well.
Thank you. I want to, the ADA leadership has confirmed that they can send the link to both the recording and the ADA slide deck to the attendees. So I'd like to thank both of our speakers for putting together the presentation. So on behalf of myself and the Diabetes and Youth Interest Group, we really appreciate the time and effort they took to put together their talks today and their work on that committee. And so I guess we will sign off for the day then. Thank you very much to everyone.
Thank you.
Thank you.